Hello, team. I am so glad to be back and able to make videos for you, share the knowledge that I get from whether it's from CMS or from our compliance team. They have a wealth of knowledge, having their master's degree and specializing in CPT coding, ICD-10 coding. We're just really blessed to have them as a part of our team. So I wanted to give you some advice, some education and knowledge, because when we go to nurse practitioner school, we're not necessarily taught how to bill or how to code. And so everything that I learn, I like to pass on to you. A lot of this video is going to be stuff that you can read. The last thing you want to do is hear my voice for 45 minutes. So I will skip over some of the slides after I've described them to you so that you can review them and you can read them, process them, highlight them, print them out, because everyone is going to get a copy of this. So our objectives today are to review the definitions of what CMS has posted. What does stable condition mean? And we're talking about a condition here, not the patient. What does chronic illness mean? And not necessarily the patient. And then we're going to talk about, and we'll do this first, the audits. And you'll be audited usually after new hire by the Vice President of Clinical Services, super smart woman who is going to look at your notes meticulously to make sure that we are following CMS guidelines. I'll be doing video audits of you, and then corporate compliance will see you in about 2 months. So you have plenty of time to get all the education that you need, all of the help writing the notes, so that when you do your audits by corporate compliance, that you'll be ready to go. So the difference between my audits, by the other nurse practitioners' audits, by the third-party auditors. Mine is going to be a video audit. I talk super fast. I have about 9 minutes to get the video audit completed. So I'm constantly looking down at my phone to do that. I might talk a little bit faster. You can just decrease the speed on your YouTube video if you need to. But what I'm focusing on is my chief complaint. My chief complaint that's going to be 2 to 3 words, maybe 4 words. It's going to have something like an assumption of care, an admit, a readmit, a follow-up, and then the diagnosis. And the diagnosis has to have an ICD-10 code. So if it's going to be a wound, if it's going to be hypertension, if it's going to be depression, if it's going to be diabetes, that is what our chief complaint looks like. Now, if you're just doing chronic care, their once a month visit, you're not going to list 3 or 4 things that are really stable up in your chief complaint. Your chief complaint is the title of the story, and it's one diagnosis most of the time. Every now and again, you might have hyponatremia and hypokalemia, and so you could add those as your chief complaint. But your chief complaint then leads into your HPI. So I've done multiple in-services on your HPI. I've got this a page for you to review for your HPI in this one. If it is helpful, use it. If any of the other resources that I give you are helpful, use them. That's what they're there for. And then I am a stickler on surgical, social, and family history. I give you 3 minutes for each section to do some investigation in the chart. If you forgot to ask the patient, or the patient has dementia and can answer. But usually asking the patient, do they have any family history of diabetes, of cardiac disease, of cancer, is so much faster than doing a chart review and trying to come up with the information. That being said, you spend about 10 minutes. I'm going to spend about 3 minutes on the total evaluation of that section. If I find something different in my first 3 minutes, I'll bring that up and mention that. It should not happen. You should already have that data in there. And then the physical exam. So this is one section I hone in on. I've got access to point-click care. I can see the patient that's got glasses on. If you haven't written visual impairment, your dialysis patient, if you haven't written AV shunt or a dialysis catheter, you're missing something. If you've got that the patient has a wound, but under skin it's clean, dry, and intact, there's some issues. So when we go in and we meet our patient or visit with our patient, what we do is our physical exam. We're talking to them, but we're doing a physical exam. The stethoscope is on them. You're looking at their abdomen. You're looking at their legs, the edema, and talking with them. So that physical exam, as the most important thing you do when you see the patient, is also the most important thing you document when you're doing your documentation. If we're talking about a vital sign that's 150/70 and it pulls in from point-click care and you don't notice that, I'm going to be looking for hypertension for one of your diagnoses and whether you're going to address it or not. Things that I don't necessarily like is we'll have PCP or primary care address the issue, evaluate the issue. You are primary care. You are the person that's evaluating. You are the person that has a blood pressure list. So if you feel like you're not able to order Norvasc, or you feel nervous about it, or you've got a doctor that's very overbearing, but you know that there needs to be a change or a change of the insulin, you're just not sure how to do it because some of their blood sugars are 100 and others are 400, please reach out to the physician. Do not put as one of your interventions, may address a next visit, may have primary care address, or hopefully they'll evaluate that. No, that's us. We are primary care. So make sure that we're doing that. And then your assessment and plan. Your assessment, your first one, is going to be your chief complaint, which has then fallen through into your HPI, which has then followed through under your physical exam or under your vital signs, and then now is under your assessment and plan. So without being very dramatic, your assessment and plan comes up to be a couple of things. One, your diagnosis is first. I don't need an ICD-10 code. If you put one there, that's fine. Number two, so after you've got your diagnosis, your assessment of that. So it's stable, blood sugar 120, A1C 5.5. If they've had their A1C done in the last 3 months, you can put your A1C there. So if your A1C was 8.9, their blood sugar was 100 this morning, is the patient stable? No, they're not stable. They're not at goal. They're not where they need to be. Now, you decide where their goal should be. So you've got a 90-year-old patient. She's had diabetes. She's on insulin. Her average blood glucoses are between 100 and 150. We're comfortable with that. She's got multiple comorbidities per the American Diabetic Association. With an advanced age, frailty, and multiple comorbidities, a goal of 8% would be ideal for a diabetic patient. So make sure that if you don't know what your ideal goal is, go to the American Diabetic Association, download the booklet. It's hundreds of pages. All you have to do is look in the table of contents and it'll show you what your goal should be. And then after you've got your assessment and plan in place, and there, let's say it's hypertension, diabetes, and depression. Under your ICD-10 codes, it should be hypertension, diabetes, and depression in the exact order. So don't forget that your assessment and plan, worst on top, most changes on top, lab orders on top, med changes on top, and then everything else goes on the bottom from there. So writing an HPI that passes CMS audits is a big deal. So there are multiple different trainings and tools that you can use. But here is just an example of one that I have. I'm not going to read it to you. It looks the same as every other HPI. Why are we seeing the patient today? What do they look like? What do they say? What do the nurses say about them? That's the moral of the story, the present illness, what's going on right now. And so now what does your audit look like from a third party auditor? So these are people that, again, have their master's and they specialize in billing and coding, not what we learned in nurse practitioner school. So, and then how much is it worth? Like, they'll give you the answers to that. So they're going to look at 5 of your notes. They're going to try to find a discharge summary. So every single patient that discharges home, you should know about it and you should be doing a discharge summary. So they should have multiple discharge summaries to pick from. Advanced care planning. So for every new admit that is alert and oriented times 3 and is a full code, you should have advanced care planning. They're looking at those. Those are the ones that they need to have meticulous. Then they look at a routine follow-up, and then they're going to actually look at the note before that, and they'll put them side by side, and they'll do a comparison. They'll highlight the words, and then they'll say, a lot of that was copy and paste. That is not going to meet the muster when we're talking about CMS reimbursement. So that potentially could have gotten declined. If that's the case, we need to really work on copying and pasting. So that's not a good place. Sometimes you can get your snippets, and your snippets from me are only 50% done. Remember, I tell you to edit, delete, adjust, and make changes to the snippets. So I've given you a blanket snippet, and you are responsible for changing what is not correct and adding to that. And then they're going to look at your ICD-10 codes. So let's say you've got your 3 assessment and plans. Again, you're going to do hypertension, diabetes, and depression, and you have 10 ICD-10 codes. So that's wrong right there. So if you have 3 assessment and plans, you've got 3 ICD-10 codes. The only thing that might change that is if you've got maybe like a urinary tract infection and you've got E. coli, you can use the B code for that. Underneath, let's say you have diabetes, you may use the insulin code below that. But ultimately, your codes should be the same for that. Now, when they get to time and MDM, it's a little more critical, and we'll go through that process. So the reason for your patient to be seen, that's your chief complaint. It needs to be very blunt, very broad, or very narrow as far as what the title of that entire story is looking like. So what caused you to come in and see him? Don't put it's a routine follow-up. Don't put generic stuff. Don't do chronic care management. It might be, in your opinion, a monthly visit. But what's the point of a monthly visit? Are you following up on their hypertension? Are you following up to see how their diabetes was this month? Are you following up to see the change that they did in psychotropic meeting last month and how they're doing? What is the rationale for that? So make sure it's very specific. So that's your chief complaint. It's worth 5%. Clarity and organization is worth 5%. So this is where you have your problem, whatever you put in your HPI, and what is included in that. As far as your patient-specific content, again, it's not choosing my snippets. It's choosing my snippets and customizing it toward the patient, or writing your own note independently every single time. You don't have to use my snippets. As far as history and present illness assessment and plan, so that pulls over to 20%. If you're putting it in the assessment and plan, my assumption is it's under the HPI as well. That's worth 20% of the audit for that patient. So remember your assessment and plan. On every new admit, you're going to do all of the medications, minus the bowel protocol, minus your PRN Tylenol, but you're going to do all of your medications. On your follow-ups, you only need 3 to 4, not 2, at least 3 assessment and plans. And then if you do 4, 5, 6, 7, 8, 9, it's overkill. But if you're trying to address all of those systems because there is an error in that, then that's okay as well. But 3 or 4 is more than sufficient. Coordination of care, that's automatically your nursing staff. However, if you're coordinating care with anyone else, that's a big deal, especially if you're trying to get a higher level of care. So make sure you do that. It's worth 5%. Your CPT coding is worth 40% of your grade, which means if you do this one thing wrong, you automatically get 40% taken off of your grade, let alone any other minimal points that you have taken off. So you have two portions of this. You have your time or medical decision making. So you're going to click 30 or 45 minutes, or you're going to click moderate or high medical decision making. That's your first section. So then when you put your CPT code, which is a 99309 or a 99310, you might have a discharge code, which is a 99316, so that might be a little bit different. But usually on most notes, you're going to be a 99310 or a 99309. If you said 30 minutes and billed for a 45-minute visit or vice versa, you lose all points for that. Medicare will not pay you. It's Medicare fraud. So it's not on purpose, but just make sure you know that a 309, a 99309 equals a moderate degree of medical decision making or a 30-minute visit. I also want to reiterate, if you're billing on time, which I would suggest every single day of the week, bill on time, you're automatically going to be safe. Your time per CMS needs to be completed on that day. So if I see, or if Tatiana sees that you have opened a visit for March 1st and you're doing it based on time, your note doesn't get closed until March 3rd, you're out of compliance. Per CMS, if you do it based on time, it has to be completed all in the same day. Here is your medical decision making. This is from 2023. It's the most updated. This is actually from the American Medical Association. It looks word for word as far as the CMS grid. I put over on the left-hand side moderate, 99309, or 30 minutes. So you get the moderate or the 30 minutes, and that equals a 99309. I want to reiterate on a high. So a high on the left-hand side is going to be a very, very, very sick patient. So they've either got a chronic illness with an exacerbation, or they've got some kind of illness that is compromising the patient significantly. Now, if you can get data, that's great. You can read a note, like a wound note, if we're talking about a wound infection. So you can read a note, you can look at a lab, you can order a different lab, and then do your coordination of care. Make sure that you don't just click nursing under the collaboration and coordination. You're coordinating with a wound team, or you're coordinating with someone else, some other professional, to make it collaborative. But usually data is very difficult to, especially if you don't have a lab, to be able to include in a high. And then you've got to have some kind of acute plan that you're going to do. So a decision to hospitalize versus not hospitalize, a decision to put on hospice, a decision to start a medication. You've got a DVT, you've got to start them on Eliquis. Is of utmost importance so they don't throw a pulmonary embolism. You start them on ertapenem or imipenem. We're talking about high-risk patients, so very sick patients that are very high risk to meet your high MDM. So if you're using the word high and you're billing 99310, make sure your patient is really high in criteria. Here's your CPT codes. It talks about a 309 and a 310. It's very important that you understand these. Again, if you get it wrong, it's 40% off your audit. Why does that count? Because CMS will take that note back and not pay you for that. You've got your discharge information on there, your advanced care planning on there, and then your smoking cessation. So all of that should help. And then your ICD-10s, they will match them to your assessment and plan. So if your assessment is chronic pain and your ICD-10 code is R52, which is just regular pain, they're going to take points off of that. It has to be G8 9.4, which is chronic pain. So if you're saying chronic pain, then it needs to match. Likewise, if you're saying left lower extremity pain, then that's the ICD-10 code and not chronic pain. So make sure that your ICD-10 codes match. Now, if I told you you got a 91, since the very first time we were in elementary school, all the way up through high school, all the way up through nursing, and then your BSN, and then your MSN, we know that 91% equals an A. We know that 81% equals a B. So if you've got a 50%, you are going to get an F. 50% looks as dramatic as an F. That's where we want to keep you away from. We want to keep you in total CMS compliance. And some people will say, I've been doing this for 8 years. I know the rules. Well, the rules just changed in 2023 and they continue to change rapidly. Just last year, we saw that CMS is now requiring the medication and the dose. So we saw that. And then we saw the CPT code being aggressively monitored. So your SNF and your LTC. So if you've been a nurse practitioner for quite some time and you've never done it this way, it's not that we're trying to do it a different way. This is the correct way. This is the CMS way. And your notes will look awesome and they'll be audit proof. That's as far as the audits go. Expect not only one of the other RVPs of clinical services, myself, and then the third-party auditors. So we're going to try to make it so that when you get to the third-party audits, you're going to get straight A's, because that's really what we want, is for you to not get A's, but to understand CMS requirements, guidelines, and to get that education. So we're going to give you a good 2 months of solid practice and working on that as we go by. So rationale for why we need to have audits, there's a whole list of them. I don't need to read them to you. Here is the definitions and discussions. I have highlighted certain areas where I feel like you need to know certain facts. So this one, like physician or other qualified healthcare professionals. So they have to have be qualified with education and training, licensed and regulated, and facility privileges who perform a professional service within the scope of practice. This is not the same as a clinical person, like a director of nursing, a unit manager, etc. So I have highlighted certain areas so that you can focus on what part of the definition is important that we need to address. Discussion in here. So here's an example of a patient that has a progression. It's a patient who had a GFR of 40 and then it dropped to 35, and now we've gotten our GFR this morning and it's 28. The patient has declined. It is organ threatening because our GFR is 28 and we're in chronic kidney disease stage 4. So the kidneys are failing and we have to make sure that we're looking at that. So when we use this as an assessment and plan, because they have a significant progression, yes, we can increase the hydration. That's important. Review of nephrotoxic medications. There is a snippet that says that, but I really do want you to look through the medications and see, wow, they're on 3 diuretics. They're cardiorenal. We got to figure out which one's the least aggressive on the kidneys. A referral to the nephrologist. Maybe even you calling their nephrologist and saying their GFR continues to decline, or calling their cardiologist. And then, do we list it in our assessment and plan? Well, yeah, the answer is that they've got a chronic illness with progression. So it would be chronic kidney disease. That would be your assessment or your diagnosis. Your assessment would be chronic illness with progression, comma, GFR 28. And then that puts us into what kind of medical decision making do we have. So a GFR of 12 is going to be vastly different than a GFR of 28. 28 we can work with. It takes a moderate amount of medical decision making. A GFR of 12 may need dialysis. So this example could go both ways as far as high degree of medical decision making and a moderate degree of medical decision making. CMS categories are about status, not the intensity of the treatment. So the CMS definitions are used to define the complexity and the risk of medical decision making, not whether you performed a dramatic intervention. That medical decision making may be, we're not going to do aggressive care, we're not going to send them to the hospital, etc. So should it be listed in the assessment with a conservative plan? Absolutely, you've got to decline. Should that be number 4, 5, 6, 7 on your assessment and plan? No, it probably should go pretty close to the top. You've got an unstable diagnosis there. If they're not stable, but in no immediate threat. So how are they not stable? We've got a GFR of 28 and in no immediate threat. They're hemodynamically stable. Their organ failure is continuing. It's progressing. We know what our plan is. We've got to get that GFR up. We've got to get that kidney function a little bit more stable. But at this point, they're hemodynamically stable. Here's another CMS problem. With medical decision making. So it's a patient that had an A1C of 8.4. Now the A1C is 9 this week. So there's no hyperglycemic crisis, no acute symptoms, no immediate medication change was implemented today. Why? It could be a lot of different reasons why. One of them might be because their blood sugar log over the past 1 week ranged from 78 to 350. So that may be something that the endocrinologist would be working with, or even you collaborating with a physician, because you certainly don't want to increase some insulin and then have that 78 turn into a 58. Here is my information. Right here, you've got my email. You've got my phone number. Now, a lot of you are aware that I do Zoom calls, Zoom videos, as well as YouTube videos. So I'm constantly on a Zoom call with nurse practitioners, helping and supporting them. That being said, I always have my phone right in front of me. So in between Zoom calls, if you text me, I will respond back. If you call me, I will respond back. And if you email me, I will respond back. I did have a nurse practitioner that said, if I can't call you, then you're useless to me. Well, if you text me, I can see it right in front of me, and then I can determine if this is an emergency that I need to step away from a Zoom call with a nurse practitioner. So our new higher orientation Zoom calls are 4 hours. Our 2-week follow-ups are 2 hours, and any meeting that I have between a nurse practitioner and myself usually are between 30 minutes to an hour. Even if we schedule 30 minutes, they tend to run over just so we can touch base and discuss stuff. Tatiana's information is here. She's an amazing wealth of resource. We do things very differently. She does the paper and the crossout. I do the Zoom videos. So you're getting a wide variety of education together. So she's doing Zoom videos as well. So you can call and reach out to her. She's constantly helping the nurse practitioners, especially the newer ones, get their feet underneath them and get going. So you have access to both of us at any time that you need. But I did want to explain the audit process. Her audit process, my audit process, prepping you for third-party audit in order to make sure that we're meeting the CMS guidelines. So if you have any questions, reach out. I'm so glad I was able to spend this time with you today. Thank you for watching. If you had to put me on 1.5 so that I would talk faster, that's fine. Read your PowerPoint, highlight the important stuff. And if you already know this, you're a superstar. If you're learning it, you're a superstar. If you're working with Mana, you're a superstar. So I just wanted to say that. And if nobody told you today that you are valued and we appreciate you, just know that you are, and we think about you. Have a great day.